Hi, my name is Claire, and thank you for joining today's webinar, Best Practices for Preterm Labor Triage, a conversation about protocol standardization and collaborative care. I'm your host, Claire Oza, and I will be facilitating today's webinar, which is hosted by Hologic. Today's agenda is as follows. After my brief introduction, we will be joined by Dr. Michael Ruma, Dr. Tori O'Daniel, and Jessica McNeil-Santiel. And following our speakers' presentations, we will have time for Q&A at the end. This webinar will conclude at 3 p.m. Eastern Standard Time. We encourage you to submit your questions using the Q&A button on your screen, and you may submit those at any time during their conversation. There's no need to wait until the end to submit your questions. And with that, I'll turn it over to Dr. Ruma.
All right, thanks so much, Claire. Just want to verify one more time you guys can hear and see me correctly, and some slides that say preterm labor. Is that a yes?
Yep.
All right, perfect. All right, well, thanks so much for joining. It's a great day to give a lecture, and thanks to Hologic for allowing myself to join you, and I'm joined by two great guests today. November 17th is Prematurity Awareness, well, it's the month, and that day is a specific day to recognize prematurity and premature birth. So it's a great time to talk about preterm labor and optimizing the evaluation to achieve better outcomes for patients. I'll tell you just very briefly about myself. I am a perinatologist. I work in New Mexico. I work for a practice called Perinatal Associates in New Mexico. Have been here for 17 years. Hard to believe that, but really, really happy to join you today and be your speaker to start for the day. I'm going to give you a brief presentation, and then I'm going to be joined by Tori O'Daniel, who's the department chair and medical director for Mercy Hospital. She also has an incredibly important job with the Society of OB/GYN Hospitalists, and I'll let her tell you a little bit more about that when we get into the fireside chat and question and answer portion. Jessica McNeil is a certified nurse midwife, has more acronyms after her name than all of us combined, and she is an amazing person. Just a brand new baby, joined her just in short order. She's also an adjunct professor at Baylor University. I think you will enjoy listening to her and her points of view as well as we dive into this. So again, just to give you a little brief overview, we're going to talk for about 15-20 minutes about preterm labor, how we might optimize that evaluation so that we can take better care of patients. And then I'm going to invite my guests back in to join us for a bit of a question answer and a live session that you guys can also join by bringing questions in to the session. Let's figure out what we're going to talk about today. We're going to talk about the problem of spontaneous preterm birth. We're going to dive into the latest research regarding antenatal corticosteroids, which is particularly pertinent today, and you'll see as we progress through the lecture today. I want to bring in also the importance of standardization. This is a key component to medical care, clinical care of patients, but particularly important with preterm labor evaluations. And then we'll delve into some real world experiences with the OB practitioners that are joining me here today. You each know this, preterm birth less than 37 weeks is an absolutely devastating issue. Were I to quote some global leaders like Roberto Romero or Stuart Campbell in the United Kingdom, these are two preeminent researchers that really say that obstetric preterm birth is the greatest issue in modern day obstetrics. It is highly problematic. Preterm birth is made up of spontaneous preterm labor, 45% of all preterm births, and PPROM, 25%. The complications don't just end with that event. The infant that's born faces significant complications. And then you can see from this graph as we approach viability at 22 weeks into 23 weeks, we have significantly elevated rates of maternal mortality at 45-50% born at those very early gestational ages. Fortunately, these complication rates and death rates go down as we progress towards the third trimester, 30, 31, and 32 weeks. But profound complications for these infants, not only immediate, but also long-term. And that is just the beginning of the story. Preterm birth affects every one of us. In the United States, we on average have about 3.6 million births each year. That number is slowly dwindling. Unfortunately, our current preterm birth rate is quoted at 10.4%. And we get overall in the United States a D plus according to the March of Dimes. I think this is an important map because having the opportunity to speak in a number of different venues across the United States and the globe, we have preterm birth everywhere. Despite your own personal experiences, this is a real issue. Whether you're on the West Coast, the Southwest, where I'm at, the Midwest, the East Coast, or the Southeast portion of the United States, we face this same issue, all in varying degrees. Despite a lot of efforts, research, and thought process on how to reduce the rate of preterm birth, unfortunately, as you can see in this graph from the March of Dimes Peristats section, we are not making inroads on this particular rate. Years ago, over a decade ago, we had a preterm birth rate of about 9.6%. And unfortunately, over the last decade, during the pandemic, rising to as high as 10.5, and today around 10.4%. We need to make efforts to improve this. And this is a real everyday problem. So it's particularly important that we're talking about this during Premature Awareness Month. Our professional society as an obstetrician gynecologist, the American College of Obstetricians and Gynecologists states that antenatal corticosteroids, or ACS, the administration of ACS prior to an anticipated preterm birth, is one of the most important antenatal therapies. And they have a variety of recommendations. And as you read this document, you'll see that a course of steroids is recommended for pregnant patients 22 and 0 to 23 and 6, from 24 and 0 to 33 and 6, and then also in the late preterm setting. You'll notice that this document from the American College has a lot of black text. That was the original portion. And then there's yellow highlights, blue highlights, and red interim updates, because this is a living document. There are changes in research, changes we're going to talk about later in the presentation, that are particularly important, and very likely you will see updates to this document in the coming years. Despite its very beneficial effects, we know that steroids are not particularly timed well. And if they're not timed well, we don't yield optimal outcomes for the preterm infant. This is a study by Razaz that is from Canada, looking at their steroid exposure. And unfortunately, this study demonstrates that when we want to time steroids properly, we think a patient's going to deliver preterm. She's in preterm labor, she's 25 weeks, and we pull the trigger on steroids. We're not doing that correctly, but for about 20% of the time. In this study in Canada, over half of the patients actually delivered after 35 weeks in the late preterm or even term setting. Can we do better? This is another study from the British Journal of OB/GYN just a couple years after that original Razaz study. And you can see that this study, the users, the clinicians, did achieve a slightly higher optimal timing rate of around 40%. But that meant that 60% of the time, we still were not timing steroids properly. Steroids originally were demonstrated to be efficacious within a day after administration to approximately 7 days. And maybe in some research, there is still residual benefit up to about 14 days after a course of steroids. But if we don't time it correctly, and here in these two studies, 60 to 80% of the time, we're not timing things correctly, we have worse outcomes for that preterm infant. This study in the British Journal was interesting because it demonstrated a bunch of different indications, clinical reasons why we're giving steroids to patients. Take a look at this one. This is kind of interesting. Asymptomatic patients. Why would we be giving steroids to an asymptomatic patient? Well, if you do that, you're not going to optimally time steroids, but for 8 or 10%. So probably shouldn't give steroids to an asymptomatic patient. These two studies caught the attention of the Society for Maternal Fetal Medicine. SMFM put out this paper just recently, 2022. And it's a special statement because they had concerns with the current state in medicine surrounding antenatal corticosteroids and preterm birth. The title of this paper is Quality Metrics for Optimal Timing of Antenatal Corticosteroids. And I might point out a couple authors, maybe Dr. Andrew Combs, the director of pediatrics quality research portion. This is the largest employer of maternal fetal medicine specialists in the country. So some very, very pertinent individuals writing this paper. SMFM acknowledges the same statement that ACOG did. Steroids are most beneficial when given within 7 days prior to a preterm birth. They recognize the two studies I just showed you. 20 to 40% of preterm infants receive optimally timed steroids. Let's flip that on its head. That means 60 to 80% of preterm infants do not. Why might we be liberal with giving steroids? Why might we not focus on the proper timing of steroid administration? This emanated primarily due to a Joint Commission metric. We have perinatal care quality metrics. And years ago, there was a metric PC03, which measured the rate of ACS administration at any time before a preterm birth. Anytime. If we went back to that ACOG statement, the committee opinion on steroid utilization, they say preterm birth within 7 days for each different discrete gestational age timeframe when we should be giving ACS. This metric specifically incentivized clinicians to give steroids liberally. SMFM goes on to review those studies about the low rate of optimally timed steroids. And then further in the paper, if you take a moment to read this particular article, which I'd encourage you to do, SMFM highlights a number of studies demonstrating that ACS might actually increase adverse perinatal outcomes when we're trying to reduce them. Studies have demonstrated that when we don't time steroids properly, we may actually yield higher neonatal intensive care unit admissions. We may yield higher rates of small for gestational age infants as well. And then the worst circumstance that's really caught people's attention is that we may notice increases in childhood mental, neurocognitive, and behavioral disorders. SMFM finishes this particular statement with the use of ACS for women being evaluated for threatened preterm labor should be judicious. And this is a word you'll hear a few more times. The study in Indiana that shows that ACS might heighten our chances of NICU admission rate is from this paper here by McKinsey et al. Dr. Haas is a very important researcher at Indiana University. Have had a chance to chat with him about this particular paper. And the primary outcomes in this study was looking at pregnant patients that show up in our obstetric triage units around the United States, just like they might show up in New Mexico. But in Indiana, if those patients showed up for the clinical indication of threatened preterm labor, did they get steroids or did they not? And what were the outcomes? 5,330 women, 28% of women received steroids around 32 weeks. And you'll note that half or more of the women delivered at 39 weeks. Not properly timed steroids in half of the pregnant patients in the study in Indiana. What they identified is that term newborns whose mothers were given ACS for threatened preterm labor actually had higher rates of NICU admission and SGA. So if a baby was exposed preterm for threatened preterm labor and went on and delivered at term, received steroids in utero, they had a 12% versus if they had not received steroids, 6% risk of NICU admission. Statistically significant NICU admission heightened rate. We're trying to reduce that, but we actually, by not properly timing steroids, are actually potentially causing harm. And the same thing goes for small for gestational age infants. Childhood neurodevelopmental outcome issues emanated from a study by Rai Koken, and this is her second paper. first one was in 2020. This was in 2022. Katri Raikoken, looking at every child that was exposed to steroids in utero and what their outcomes were from birth to age 12. We are not capable of really doing this type of study very easily in the United States because our maternal EMRs and our child EMRs are not well linked. But in European countries, they particularly are well linked. And so this study looked at developmental disorders in children exposed in utero to steroids. Did they develop any speech and language issue, scholastic skills issue, motor function issue, pervasive developmental disorder, that would be like Asperger's syndrome and autism, anytime from birth to age 12? In the overall cohort, children exposed in utero to steroids had a higher rate of developmental and neurosensory disorders with a hazard ratio of approximately 1.4. This finding, when you dichotomize the group, is found in term-born children that are in utero exposed to steroids preterm, a hazard ratio of almost 2.2. If the child was born preterm and received steroids preterm, there was no associated adverse outcome. So if we're not timing steroids properly for that preterm infant, and the infant doesn't actually deliver preterm, but it goes on to deliver a term, we actually have strong evidence that suggests in a large epidemiological study that we may actually be contributing to harm for that newborn. These particular studies, and there are many more if we had more time to discuss, but I want to spend time chatting with my colleagues. These studies have produced a lot of thought process on this particular topic. This is an editorial in the American Journal of Obstetrics and Gynecology. You might recognize some of these names: Michael Belfort, George Soddy, Aaron Coy, Ron Wapner. These authors are some of the most preeminent researchers in the United States today doing obstetric perinatal research. They state, we cannot overlook the fact that ACS treatment is not a totally benign treatment. Antenatal corticosteroids exert a wide array on metabolic, endocrine, and immune areas in the fetus and the human, more than any other known biological ligand. The primary target of ACS, we're giving that steroid injection and repeating it 24 hours later. We're giving those steroids to the mother so that they can get to the fetal lungs. That's where they help reduce respiratory distress syndrome by increasing surfactant. But steroids can affect numerous other tissues, including the developing fetal brain, which contains a high level of corticosteroid receptors. These authors go on to say that even a single prenatal course of steroids administered at any gestational age may have a benefit, but also may have a harm. Very interesting calculation that these authors did. Our primary goal by administering steroids to a pregnant person who's in preterm labor or any other circumstance that anticipating a preterm birth, our goal is to reduce RDS and a variety of other outcomes such as NICU admissions, IVH, necrotizing enterocolitis. In order to reduce one case of RDS, we need to treat 38 patients. But the number needed to harm if we're not timing things correctly and that child goes on to deliver a term, the number needed to harm is also 38. The balance is not quite there. If we go back to the SMFM guidance, which these authors from the prior paper really would suggest that prudent use of steroids should be dictated by this particular paper. SMFM and this particular special statement encourage clinicians, us, to thoughtfully evaluate the risk of preterm birth within 7 days before we give steroids, particularly if that person's risk is low. We want to avoid administration of steroids in patients whose risk of preterm birth is low. SMFM gives us 2 examples, and I might point to this one first. The asymptomatic short cervix patient. If she's asymptomatic, SMFM would like us to not do anything. If the patient comes in with preterm contractions and we complete fetal fibronectin testing and we receive a negative test result, they also would like us to not do anything and avoid administration of steroids in these settings. In Prematurity Awareness Month, how can we make an impact? We all know this room. This is an obstetric triage room. Typically, it's a dark room, no windows, where we can interrogate the patient about all of her symptoms and evaluate what's going on. She doesn't really want to be there. She wants an efficient, high quality evaluation to determine what's going on. She came in maybe with symptoms of preterm labor. We can do a clinical assessment. We can do an ultrasound, and we can do laboratory testing like a fetal fibronectin biomarker. Many folks deliver or rely on cervical examination alone, and I would provide caution in this realm if we want to actually improve our outcomes with properly timing steroids. If a patient is 1 centimeter dilated, 85% of these patients go on to deliver over a week later. If she's 2 centimeters dilated, 70% of these patients go on to deliver a week later or more. Cervical dilation by itself is not a predictable outcome and should not solely be relied on, in my clinical opinion. Transvaginal ultrasound, perfect. I'm an MFM. I love doing these. If you're going to do them, please know how to do them. Look at pictures for 3 to 5 minutes. Assess this cervix. This cervix looks totally normal. It's curvilinear. The anterior and posterior lip of the cervix are thick, and the cervical length is 4.8 centimeters. But if you're too quick, maybe you're in a hurry, you don't wait 3 to 5 minutes to take your imaging and your acquisition of these pictures, maybe you miss the fact that the patient actually has a very short cervix at 5 millimeters with a U-shaped funnel. This is where fetal fibronectin can be a very good objective test and point us in a direction as to how to counsel the patient. Fetal fibronectin is a glycoprotein. It's found at the maternal-fetal interface of the amnion and the chorion. People have called it a glue holding a pregnancy in research papers before. It is FDA approved for evaluation of symptomatic preterm labor from 24 weeks and 0 days to 34 weeks and 6 days. It should be collected during a speculum examination and when the patient is under 3 centimeters dilated. If the test is positive, that we'll talk a little bit about what to do with that. But if it's negative, the test has an incredibly high negative predictive value. 99% of patients will not deliver in 7 or in 14 days. The author Peaceman, I reflect on this because this study is from 1997. The author knew that this test's benefit lie in its negative predictive value for impending preterm birth. And the author in the discussion portion of the paper says, if we rely on the NPV of fetal fibronectin and trust it, it would suggest that less intervention may be appropriate. This is why SMFM in 2022 is still saying that in its most recent paper. If you're going to make a decision, though, about should I give steroids, then we should look at all of the clinical information we have. What is the patient's cervical length? What is her fetal fibronectin test result? If the cervical length is abnormal, under 30 millimeters, and the fetal fibronectin is a positive, so both tests are abnormal, a biochemical test and a bioanatomic test, risk of that patient delivering in a week is 45%, according to Gomez. Well, that's very good information. If the FFN was negative in that setting, it's 11%. Maybe we should talk to the patient and ask her what her desires are, using actually shared decision-making and good counseling. We did some pre-test counseling. Now we're going to do some post-test counseling now that we have data. You have a cervical length and you have a fetal fibronectin result. What if the cervix really short, under 15 millimeters? Yes. Fetal fibronectin testing positive? Yes. This patient has a 75% chance of delivery within 7 days. Patient definitely deserves antenatal corticosteroids. But it also shows that if these things are negative, we should not be administering steroids because we're very, very likely not to optimally time them. There's a variety of studies that I could go on and on about how fetal fibronectin testing in a variety of reviews have decreased maternal admissions, decreased length of stay, and decreased antenatal corticosteroids. And I would encourage you to read some of those. There's numerous reasons we don't follow these approaches. We think we're smarter than each other. We have autonomy as clinicians. We have very little oversight and enforcement. We have different levels of concern. And for all of these things contribute to a lack of a standard of care. You can see this lack of a standard of care in current practice in America. This is a paper written by Sean Blackwell in 2017, looking at 5 massive state insurance databases of how pregnant patients that have symptoms of preterm labor are evaluated. 23,000 women evaluated. A fourth of them are admitted. These patients are probably significantly dilated, straightforward, but 3/4 of them, 75+%, are discharged home. What happens to them? You saw her in triage. We discharged the patient home. But interestingly, like the majority of them deliver much, much later. But very concerningly, 20% of those patients that we discharge from triage come back and actually deliver preterm within 3 days. This is the high risk group. What did we actually do to evaluate that particular group that has a really bad outcome? Let's see what we did to that group. Well, 80% of the time we did nothing. We did no fetal fibronectin testing. We did no transvaginal cervical length testing. I spent the last 15 minutes talking to you, 20 minutes talking to you about how SMFM would like you to do this, how important steroids are according to ACOG and SMFM, how these tools can work in conjunction with each other. I think it is wholly time that we begin to make improvements in this area. There are ways to standardize protocols. This is one from IMES based on the March of Dimes Preterm Labor Assessment Toolkit that's been in existence for many, many years. And this is a more modern day, a little bit more simplified approach. Patient presents with symptoms of preterm labor during that indication time, 24 weeks and 0 days to 34 weeks and 6 days. The patient should have bispeculum, a fetal fibronectin collected. If she thinks she's ruptured, evaluate that. But if she's here for symptoms of preterm labor, we don't need it. Collect her infection workup and a GBS workup. Then we want to move on after we've collected all of those things. If she's under 3 centimeters dilated and she has a negative fetal fibronectin preterm labor test, she's got a low risk based on science, and we should discharge her and not do anything. In the patient that maybe has a positive fibronectin, only 20% of patients in studies show us that they actually will have a positive fibronectin. So you're going to rule out 80% of preterm labor triage patients. In this person, this is the one where maybe we integrate the cervical length. And if it's really short, then they're at high risk. But if it's really long, then maybe they're less risky. Using a protocol like this likely achieves greater outcomes. I'll end with that last article, this updating the balance between benefits and harms of antenatal corticosteroids. When I was in medical training, residency, and fellowship, quite frankly, I never thought there was a harm of antenatal corticosteroids. But now with the plethora of research around this area, we need to understand that there is potential adverse perinatal outcomes. These authors at the conclusion of their editorial want us to ask a question. Do you think the baby will be delivered within a week? If you don't think that the baby is going to deliver, ACS should be withheld. If you do think the baby is going to be delivered, then ACS steroids are indicated. We believe we are ethically and morally bound to reconsider the way we approach this. I really appreciate the opportunity to start off the conversation today. I want to invite my colleagues, Dr. O'Daniel and Dr. Jessica McNeil, the doctorate of nurse practitioner who has more training than all of us, to come and join us. And I'm going to stop sharing so you can see us. Hi, team.
Hi.
I might ask you guys if you want to just tell the audience a little teeny bit more about yourselves.
Sure,
Tori,
Jess,
you want to
go
start?
for it. Oh, sure.
Okay.
Yes, of course. I am Tori O'Daniel. I'm an OB hospitalist in Oklahoma City, Oklahoma. As he mentioned, I also am actively involved in the Society for OBGYN Hospitalists. I am currently on the board of directors and serve as one of the officers. And we actually just sort of released a formalized statement between SMFM and Society for OB/GYN Hospitalists that we really find value in understanding the importance of collaboration between these two entities. So from that statement, we've created a little task force that will work on very specific tasks and prioritize really what we can do together as two societies to be able to bring us together and work in better collaboration.
All right, we definitely want, thanks, Tori. I want to talk about that in a moment.
Yeah.
Jessica, you mind introducing yourself too a little bit?
Hi, I am Jessica McNeil. I am a certified nurse midwife in Dallas, Texas. Also adjunct faculty at Baylor University and Texas Women's University. I work in both a community setting and an academic medical center, so get to kind of see both sides of um, how things differ. Also get to see patients that we get from more rural settings. So really get a full breadth of patients that are experiencing preterm labor. And I'm also very involved with AWAN. So thank you for having me.
All right, well, thanks for coming. I've done a lot of talking already. I want to ask you guys some questions and hear from you. We talked a bit about the standardization of preterm labor evaluation and its assessment. Could you give me just an idea? Obviously, you're deeps in your career, you've worked in different areas, training, and maybe a couple different environments. What have you seen in your own experience? And then secondarily, what might be some benefits were we to try to, encourage all clinicians in an institution to follow one path? And I might start with you, Tori.
Sure. I've seen a pretty significant evolution in just the way that we actually evaluate and triage OB patients. So just recently, there's been a pretty large transition, specifically in my facility, from going just with OB triage, where the patient is assessed by OB nurses that then call an OB physician at home or in clinic to discuss what their presentation is, what their evaluation is. And now we are really in popping up with OB-EDs, where there is an OB hospitalist like myself, sometimes in collaboration with certified nurse midwives like Jess, and we evaluate the patients as they present. So I feel like there's such good opportunity for us to create these types of protocols with those of us that are immediately seeing these patients when maybe that wasn't entirely happening prior to that transition into an OB-ED.
Jessica?
And I would say coming from, the nursing perspective, I remember as a new nurse, part of my orientation was memorizing each different physician's preferences. And we had a big binder, and it was, it would be like, Dr. Ruma likes this size gloves, has this preterm labor protocol, likes these sutures, and how confusing it would be if another doctor was covering for that doctor, but it was that doctor's patient, or we had a new nurse working, or, God forbid, you forget what their preferences were. And what that led to was really kind of gaps in care with some patients, and could lead to some implicit bias. And so we really worked together through our like nurse practice council to create some standardization, and adopted a protocol so that every single patient that came in could get the same assessment, and it wasn't based on one particular provider's preferences. And that really helped the nurses know exactly what to do every single time that a patient came in, and it also helped the providers, because really the nurses at the bedside are the eyes and ears. They're the ones that have boots on the ground, that initially interact with the patient when they come in with their complaints, and so it really allowed them to be able to assess the patient and make sure that they got that thorough assessment, and sometimes provide a reminder for the provider and saying, hey, we got to make sure we get an FFN, or the patient hasn't had this, or I think she needs another cervical exam. Her labor process is changing, and we really saw a huge improvement in outcomes with that standardization.
Yeah, I like it. I think that I'm just laughing about all of the personal physician and midwife preferences that the poor nursing staff have to try to remember. Yeah, definitely can see a point to trying to streamline the path and maybe have a institution specific path instead of a doctor or midwife or provider specific path where we're all going in different directions. Could you guys tell me a little bit about some of the tools? I spoke about a couple. I think there's a lot of conversation uh, in recent reports of we might call low resource settings or high resource settings. I think a lot of us work in tertiary level hospitals, quaternary level hospitals. Sometimes there are facilities that maybe don't have as many things, but maybe only have a laboratory test available. How do you guys go about, how would you recommend navigating kind of a low resource versus high resource area? Can I hand that one to you, Tori?
Yeah, I think it's a great question. It's a good point. I've worked right when I got out of residency, I worked in a small critical access hospital where utilizing a fetal fibronectin was very delayed because it was a send out for me. So I couldn't actually get a result sometimes within a day or two, which, then directly affected the way that I could care for them, whether I placed them under admission and then just kind of watched or what have you. So I think we need to be mindful. I love the standardization sort of checklist. I love simulations and that kind of thing, but we need to be mindful that these templates and just like the template that you wrote, that you showed us, was to give us a guideline of how to use these steps with resources that are in your tangible option to grab. And so sometimes you may need to incorporate teaching your staff how to do a cervical length if you don't have access to getting a fetal fibronectin, so you can at least get yourself several steps down into that algorithm. And then if you still have some concern, you could in fact send a fetal fibronectin, but recognize that that piece of information may be a little delayed getting to you. And that'll look a lot different when you're doing this in a tertiary center, and I can have those things at my fingertips within an hour or two of time for my beginning of my evaluation. So I think it's really important that we keep these templates in mind, that they are in fact templates and that we can alter them based on your facility specific needs.
What do you think, Jessica, on that topic? Kind of low versus high or rural versus big city facilities?
Well, I completely agree with everything that she said. It's really important to look at your facility, look at what's available to you, and what important stakeholders you have, and then utilize the tools that are available to you to really make a process that makes sense where you work. Um, Keeping in mind also that nurses are it is within a nurse's scope of practice to use a speculum. If you are in a more rural setting, utilize your nurses. Allow them to be the ones to collect. Your FFN. If you don't have providers that are in house or you don't have OB hospitalists, which is the case at a lot of the facilities where I live. And so, really allowing all your stakeholders to work to their full scope of ability, working with your lab, because that can look different depending on where you are, of how quickly you can get that result back. Some places you may have the provider send the patient to the hospital with the FFN collected in office and ready to go. And so, if that is a process that works well for your facility, then really implementing that to tailor to work with what's best for you.
Yeah, I like that a lot. Two comments on your answer there. One, fibronectin testing typically takes about less than 30 minutes once the swab is in a laboratory and they're doing the test on the actual analyzer. In my own experience in different settings, from residency to fellowship to working in practice now, highly variable timeframes, right? How does the swab get to the lab? Does it go up some fancy chute and go through a vacuum system down and drops into the lab? Or does maybe somebody take it by hand there? So I think recognizing that the throughput can be improved with efficiency if we actually have the template, but then work through what is the proper path that we want and talking to the lab. This is an important test. This test is going to help us get a patient discharged in a timely, efficient fashion. So walking through that with the facility, I think, is critically important. It's one thing to have testing available, but also like how efficient can we make the testing, and working with your laboratory directors and walking through what that process is exactly. And then I wanted to kind of point out the involving the nursing staff. Having worked in a variety of different areas, um, I've worked in settings where the nurses do an entire workup based on a protocol, the known protocol, and then call me with the information and ask for what's the decision making. And then I've had some where if that's wholly not allowed for some reason. But Jess, maybe could you talk just a little bit about empowering uh, the nurse and how they could work up to their license, the true value and level of their license by doing a speculum exam.
Absolutely. So, once again, it is important to note that, like I said, it is within a nurse's scope of practice to use a speculum exam. Now, in a more rural setting where you don't have a provider that's immediately available or in-house all the time, that's could be a really needed skill that you can teach your nurses if they don't already have. Versus at like a large academic medical center, you have residents, faculty, um, all different levels of learners immediately available at your fingertips. And so it may not be necessary when you have people in house 24/7 at the provider level to do that collection. Um, but in places that don't, this is a very easy skill that a nurse can learn, that can be part of your annual checkoff, so people can gain comfort with it. And that does allow that provider who may be covering both in office and in the hospital to get a piece of information when the nurse can come in and collect it, not have to wait for a provider to come in house. Your nurse can collect it as soon as that patient, hits the floor. It's more time efficient for the patient because they're not taking all the time variables of a provider coming and going to the lab, waiting for it to result. And it's more time efficient for the unit as well, because if that comes back negative, then the nurse can call the provider and say, hey, the patient, their FFN came back negative, their cervical exam isn't changed. Are you okay with them going home? And on the flip side of that, if they need to be seen quickly, then or something changes, if the FFN comes back positive, certainly if their cervix is changing, if the clinical picture is changing, then the nurse can give that provider that needed critical information to say, I need you to kind of change your plan and we need you here so we can safely care for the patient.
I like it. Tori, I want to follow up with you, given your SOGH ties, and ask you specifically about, nursing shortages, physician shortages, OBGYN shortages, these OB care deserts, and a desire to, make care equitable and high quality and develop these OBEDs. Um, how talking in regards to using all of the people on a care team, have you seen in your experience where people have gotten creative where maybe it's not always the physician having to do this workup in an OBED?
Yeah, absolutely. I mean, she hit the nail on the head to be able to use um, knowledge is power, right? And to recognize what somebody's scope of practice is. I mean, when she and I spoke on the panel, you would be amazed at how many people raised their hand and thought that nurses were not allowed to do a sterile speculum exam. And I would reframe that and say it's just because it was one of those things that it's because it's the way we've always done it is the answer. Like we've always done it this way. And so I would encourage hospitalists in conjunction with their nursing team to challenge that a little bit and recognize that a lot of this evaluation can be done in rural settings. It can be done alongside physicians who are seeing somebody that might be more acute in an OB/ED to get the nurses to start that triage process and get that going. And I would even take a step back further that it's part of the hospitalist team to be a part of that champion for change and really understand the detail of education to go back to the why. For some reason, I feel like in the midst of this growth and understanding that steroids can in fact be harmful, got missed somewhere. And I don't really know why, or if there's one particular reason why that happened, but I do feel like educating people to not be as flippant with giving it, because it's sort of assumed that we could give it like Tic Tacs, for lack of better term, but understanding it can be harmful. Emphasizing the importance of this algorithm to how you think through this process, and then empowering every person in your team to be able to play a part of that. It's kind of like big picture, but really it's little small steps to get there. And I think that hospitalists have such a perfect place to be able to collaborate with your nursing team, because hospitalists get really close with nursing teams and midwives that are in there, that we're all there together all the time. So
I totally agree with you. I'm going to bounce to one question from an audience member who is asking, how do nurses get trained for sterile speculum exam? Jess, could I maybe have you answer that one?
Absolutely. Well, first off, Hologic is a great resource. Where you can have midwives like myself or other providers who are happy to come out to your facility and train you. But then also have a physician champion or provider champion at your facility. If there's someone, a provider that you work with that's willing to do that training right there with you, then that's a great way to kind of do a project that facilitates your providers and your nurses working together. It's a really easy training. Like I said, Hologic has great resources that they can help with that. Or if you need somebody from Hologic to come and help facilitate that, they're always more than willing and want to do that, want to help in any way. But use the providers that you have. It really helps, bridge gaps and really strengthen relationships when we learn from each other. And I'm sure they have great tips with the tools that you have at your facility that you can use.
Um, can I bring it back to Tori? You mentioned at the beginning a new engagement with the Society for Maternal Fetal Medicine and the Society for Obstetric Hospitalists. Where do you think? What are some of the hot topic areas where these two organizations can work together?
well, there's a lot. That's a very loaded question. But the reason that this was initiated was because of exactly what you said, that there's a large variation of how people are functioning, meaning whether it's a maternal desert or in a tertiary center. So those are extremes. And the biggest concern was that we don't really know how we all fit in this puzzle, and how do we work together, collaborate? How do we work in a tertiary center where your MFM might actually be on the floor with you working, versus you're in a rural space or a maternal desert where the only access I have to an MFM is just by a phone consultation. So I would say that really the beginning of this is just to talk about some of those high risk patients. Like one of the main topics of high risk patients is helping our maternal desert colleagues to recognize when they should be seeking out help or assistance, when they can kind of gauge to transfer a patient. Do they need to transfer a patient? Can they help co-manage this in their facility for a certain time? That's just one of many topics that we've had a conversation about. And really, our goal is to help prioritize those and then kind of outline what that looks like so you can tailor it based on what your current resources are. I know that that was a very vague response, but there's so much for us to prioritize. So I don't know that I could list like a top five.
Yeah, no, I just want to bring up, I think it's an amazing and really timely opportunity. I love seeing societies work together in general.
Mhm.
I think traditionally they work in kind of silos,
Absolutely.
and we're all putting out different statements at the same time. So I was really pleased to see in September that that announcement was made. And I hope that particularly preterm labor, maybe one plug for that, would be a hot topic, because each of us on this call, we are involved in that. The nursing staff, the OB hospitalists, and the MFM, we all work in kind of this triad to make the right decision for the patient. And if we get everybody at the table, develop a plan of attack ahead of time, maybe we can actually make it much more efficient for the patient. I'm going to bounce to a couple questions so that we can. I don't want to miss a few of these here. Um, One of which is I was informed by an OBGYN if the patient has a short cervix, there is no reason to perform a fetal fibronectin test. Is this correct? I'll let both of you maybe address that. Dr. O'Daniel, maybe you can
Yeah.
go first.
Yeah, I think that that's a great question, and it's a really vague statement for an OBGYN to make, because what is short cervix? And I think this is the exact reason why an algorithm or a template for you to have helps identify what exactly does that mean. In fact, does it mean short cervix on a digital exam, that it feels short? Does it mean that a cervical length has been performed? Was that cervical length performed by somebody who doesn't do them on a routine basis, hasn't been certified to do them, et cetera, et cetera? So I think the vague statement is incorrect because we don't necessarily know what they were referring to as short. And if you saw in his previous algorithm, identifying whether we're less than 3 centimeters, less than 1.5 centimeters, less than 2.5 centimeters, really is something that you can identify in that algorithm to then utilize the fetal fibronectin to your advantage.
And Jess?
I would completely agree with Dr. O'Daniel. You would see that depending on who is doing your cervical length, and that's assuming that they're making this assessment with a transvaginal ultrasound, that it might be different. It might be different based on their level of experience, whether you're working, with a highly trained MFM or somebody still in learning, such as one of our resident doctors, or just a sonographer that's coming down from the ED in the middle of the night. The parameters as to what that provider considers short may vary. There doesn't seem to be a general consensus across the country of, how short is too short. I would encourage you to respectfully challenge that and get some clarity at your facility as to what that particular provider considers to be a short cervix, and when they say that is a short cervix, and what is the next step that they are wanting done for that patient.
Yeah, I'll take that up. I'll agree with both of you. I would point this question answer to that Gomez slide. Cervical lengths, lots of different numbers. Under 30 millimeters in general considered beginning to be not normal. Under 15, particularly not normal. And then particularly important to add the fibronectin testing to both of these to provide some statistical prediction. It is really useful if they're both negative. There is essentially very, very, very little chance that patient's going to deliver in 14 days. So pertinent to provide two pieces of information to the patient. If they're both abnormal, very abnormal, positive fibronectin and extremely short cervix under 15 millimeters, we're upwards of 75% or higher that the patient's going to deliver in 7 days. This is, real valid clinical information for the patient and for us to make a decision together. I liken this often to, a patient that goes to the emergency room. When somebody has chest pain and they go to the ER, they always get two tests. They get an EKG and they get a troponin. One is an electrical test and one is a lab test, a blood test. And so we do the same thing, and we always do those two tests. We never deviate from that. So I would definitely encourage you to work through that with the OB, and like Jess said, advocate for the patient and challenge that approach, because just because somebody says that may be quote unquote true, it doesn't really mean that that's always the way it's true. All right, let's
Dr.
go.
Ruma, can I ask
Yes,
you a
ma'am.
question?
Yeah,
I saw one
yeah,
on the Q&A that I would love your
yeah.
opinion on, because I know what we do at my facility, but I'm just curious. So it said, if somebody comes in as a PPROMer, do you use cervical length and FFN to try to improve your timing? Because at their institution, they just give it right when somebody gets diagnosed with PPROM. So I love that question.
Yeah. Okay. Yeah. In the setting of PPROM, no, I would not utilize cervical link nor fetal fibronectin to time steroids.
Okay.
80% of patients are going to deliver within 2 weeks after they break their bags of water. So that would be an immediate medical indication to administer steroids and not use fetal fibronectin testing. Are there any other ones you want me to answer? Let's
I
see
don't think
here.
so. Let me look through, but I don't think so.
The other question here was, is there a minimum length of time between administration of antenatal corticosteroids and benefit to the delivering preterm fetus? AKA, right before an unanticipated preterm delivery, she's 30 weeks, she's breech, she's 2 or 3 centimeters dilated, and she seems to be very active. And you're going to progress towards a cesarean section at some point. What should we give her steroids, and is there a benefit? Dr. O'Daniel, you want to comment on that?
Yeah, I honestly don't know the answer about the minimum time, but we do that exact thing. So if we believe delivery to be imminent, we tend to try to give that first dose of steroid, regardless of the length of time that delivery is going to be. Because, occasionally you do have those that you think are going to be where you're imminently delivering at that moment. And sometimes you delay a little bit. So we always give it.
Okay, and I'll give you the minimal answer. I think in bench research, maybe within 3 hours, steroid, that initial shot may have some effect in large populations on a preterm baby. And I think to your real world OB hospitalist, I mean, sometimes we have to juggle patients, right?
Sure. Yeah.
She seems very acute, and then we actually need to do something more acute, and that patient's percolating, waiting maybe 6 or 12 hours. Maybe she slows down a little bit. So I think that that's really, really important to recognize. And also to the point of just efficient triage, efficient OBEDs, make a quick evaluation so we can get quick treatment for the patient and see some benefits. I might take, there's one other one here. If I can, yeah. Can the FFN swab be collected without a speculum? Can I give that one to you, Jessica?
Thanks, Dr. Ruma.
I can follow up too.
Yeah. No, so it is only FDA approved to be collected with a speculum. So um, different things may happen in different practice settings, but it is FDA approved to be collected with a speculum.
Yeah. And I might follow up on that and just say that you learn a lot by using a speculum. I mean, physical examination, you may immediately, without doing anything, see, a butt, and
Right.
she's 8 centimeters dilated. And if you don't want to deliver a breech baby, maybe you move quickly to get Dr. O'Daniel and her team to do a cesarean section. So I think basics, history, and physical examination, that speculum is very, very important. We have 2 minutes. Can I give you guys each on Prematurity Awareness Month, November 17th coming up here, just 30 seconds on this particular topic, some final thoughts. Dr. O'Daniel?
Yeah, I honestly just want to reiterate the fact that educating your staff, nurses, midwives, physicians, whatever type of specialty within our field, I absolutely feel like we need to be empowering people to understand that we have the tools at our hands and to understand when to use them appropriately. And I think we just need to make sure that everybody is aware how to use them in the right way.
And Jessica?
And I would just say, a lot of times we see patients for a very, very short and quick time. And so we have a really brief amount of time to make a decision about something that could impact them for a really long time. Having a baby in the NICU, having a baby that may come with some disabilities that come with preterm birth. And so being able to make a correct assessment can make a huge outcome in their long-term life, even beyond when you may see them. And so I think I challenge all of us not to forget that the power that we have and that we hold in just using all of the tools that we have to ensure that they can get the best outcome that they can.
Yeah, I'm going to leave it at that, Jessica, because at the end of the day, do what's best for the patient in front of you. And I think you said it so beautifully. I really appreciate the two of you joining me today to talk about this important topic. I want to thank the audience for taking your valuable time out to listen to us today. And if there's any further questions for us or members of the Hologic team, please feel free to reach out by email at ffn@hologic.com, and they will definitely get back to you. thanks again for taking the time, and I hope you guys have a great rest of the week.
Thank you. Have a great day.